Get more from your cardiac PET imaging with HeartC software from Bracco. HeartC. See the potential. Introducing Dr. Nils Johnson, Professor of Medicine in the Division of Cardiology at McGovern Medical School University of Texas Health Science Center at Houston, and Distinguished Chair of Heart Disease at the Weatherhead Center for PET Imaging. Measure or simulate PET flow versus FFRct.
Hello, everybody. Thank you so much for the opportunity to talk about PET flow and FFRct. My name is Nils Johnson from the University of Texas in Houston. These are my disclosures, nothing that relates specifically to this talk. And I want to start off with a case, and you probably heard that old joke about the person who has one watch always knows the time, but a person who has two watches is never sure. And that's sometimes the case when you do multiple tests on the same patient. This man was 59 years old and had a decreasing exercise tolerance and more dyspnea, but there's a fairly long-standing history of asthma. You can see it was treated with a few inhalers and oral agents. Also obese, BMI over 30, and a little bit hypertensive when the patient came for the PET scan. On the kind of typical medications, you can see for risk factor management, and had an abnormal FFRct scan, and so was referred for a PET study. Caffeine on the day of the study was negative, and wall motion and ejection fraction were normal. This is the FFRct report that he brought in. You can see the kind of layout here. It focuses on each of the three major epicardial arteries. The FFRct in the circumflex and RCA was reasonable, but the FFR down by the apex of the LAD was 0.67. And so here are our PET images. You can see that resting perfusion, relatively normal, stress perfusion, also relatively normal. And of course, we do measurements of absolute stress flow and absolute coronary flow reserve and put them together in something we call coronary flow capacity. And you can see that that actually, for the whole heart, matches up with normal values that we've measured then in young, healthy volunteers. And so in a way then, this is a bit of a conflict, right? We have, you can see the exact numbers there, rest flows in the anterior septal region of about 1.2 cc's per minute per gram, which is a little elevated above the average normal range. Stress flows, though, are excellent, approximately 3 cc's per minute per gram, and a coronary flow reserve of almost 2.5. And, you know, when you look at the rest and uptake stress images, not too much there. There is on the relative stress flow images a little bit of something in the anterior walls, such that it drops down to, you know, maybe 0.77 or something like that in the if you average the anterior and septal walls together. But you know, nothing that would be low like the FFRct value of 0.67. And the reason I mentioned relative stress flow is that's what FFR seeks to measure. It's a metric of relative stress flow, the stress flow in that area compared to the most normal area in the heart, assuming that there isn't some kind of triple vessel disease. And so this raises the general topic that I want to be talking about today, and that's that asks, how should we compare diagnostic tests, right? We get this enormous tsunami of information from everything we do. We got CTAs that patients bring to us, sometimes even with post-processing things like FFRct. We have SPECT images and PET images. We have absolute flow, and then we have invasive coronary angiograms as well as FFR values that are measured invasively. How are we to sort through this enormous amount of information and try to understand the advantages that one test offers over another, or if they're actually providing the same ultimate clinical message, and we should largely consider them equivalent? And so in order to do that, I want to step through a series of bite-sized nuggets. And the first nugget then is to talk about the history of why people started to do flow hemodynamic simulations. And this goes back a long way now. You can see this is the first time that I'm aware of that it was performed. It was back in 1977. This is back in an era where really angiography was all that there was, and so began to be making biplane images and would outline the coronary artery, do quantitative coronary angiography in order to define the stenosis geometry, and then assume that, as you can see here, 1 cc per second flows through, or 2 or 3, and using the basic hemodynamic equations, then figure out the pressure drop across this lesion. So that's something that has been going on now for, like decades. Ultimately, what this led to then was work that was something that available on QCA systems in the cath lab. This is stuff that came out then in the 1980s. You can see that some of my colleagues developed a lot of the theory and practical implementation behind this, taking quantitative coronary angiograms along the length of the vessel, making assumptions about the amount of flow that goes through there and how the myocardial bed reacts, and then using that to predict either the absolute pressure gradient across the stenosis or coronary flow reserve, which was kind of the interest then in the early mid part of the 1980s. Ultimately, the reason that this kind of peaked in the 80s and then dropped off in the 1990s is because in the late 80s and early 90s, people began to develop intracoronary sensors that could actually measure what the pressure loss was, what the Doppler flow velocity was in the blood vessels. And so while it had been something that was really only feasible in animal models in the mid to late 70s and then only through simulation work in the 1980s in humans, eventually people could make these measurements directly. And so the necessity of predicting these kind of fell by the wayside. And that's why we see several decades of dormancy before it revitalized itself in the 2010s with tools like QFR or FFR angio. And these are methods that harken back very much to that work of the 1980s of using biplane QCA methods, simulating the amount of pressure loss along the vessel, and then through ratios turning that into an FFR-like measurement, as you can see from the examples here. There are currently, I think, something like 6 tools. This is a summary paper that just came out this month, looking at a broad range of indexes that have been put forward by various industry partners. You can see largely looking at trying to simulate FFR, although Philips is working on its own non-hyperemic pressure ratios. And there's different amounts of clinical literature behind them. You can see that QFR has done some of the most numerous trials on this. They have their acronym called FAVOR. You can see FAVOR has done pilot studies, and it's kind of then like has sequels, FAVOR 2 and 3 and 4 and all that kind of thing. And looking at some of the C statistics down there as methods for predicting invasive FFR. It's spilled over in the 2010s as well to non-invasive angiography. So we can take all of the same principles that were derived in the 1970s and honed in the 1980s and apply them to any angiogram, not just invasive angiograms, but also angiograms taken using CT angiography. And the first tool that's out there is from a company called HeartFlow out in California. Their metric is called FFRct. You can see that image then in the upper left from 2011 when they began their first kind of diagnostic validation studies. But since then, other manufacturers as well, Siemens down there in the bottom and Toshiba up in the top right, have developed also very similar like metrics, largely called CT-FFR. You can call it CT-based FFR. I'll just refer to all of these things as FFRct for simplicity, but realize that there are different software packages out there being offered by different vendors that do have different back-end computational models. Some of these are full computational fluid dynamic simulations, and others are what we call lumped parameter models that make assumptions about the epicardial pressure losses as well as the myocardial ability to vasodilate in response to hyperemia. So with that history that this has been going on for decades now, and ultimately we're seeing then as a repetition of an idea that has come many times before. I want to move on to the second section, dealing with an issue that we should talk about a lot more in medicine than we do, and that's when we make a measurement, be it of anything, how much imprecision is there in that number that we write on the report, or we say to a patient, right, your LDL is this, your glucose is this, your ejection fraction is this, your FFR is this, this is your perfusion. And everything that we measure has this kind of imprecision, including invasive FFR. what has been very clear from a large number of publications that this slide kind of summarizes is that FFR is, number one, independent largely of hemodynamics. You can see on the left-hand side where they would make two measurements, one just using standard adenosine and then the other one while doing that with pacing or nitroprusside for changing the afterload or dobutamine for changing the contractility. And you can see that they actually really match up quite well. So it's largely immune to those kind of effects. The other two studies, as summarized in the middle and the right-hand side, ask the question, if you make one measurement and then a short period of time later you make a second measurement, how well do those two measurements agree with each other? That's something called the test-retest dynamic. And you can see here that largely there's no bias. That is, the two values on average are the same, sometimes a little higher, sometimes a little lower, but on average they give you the same answer. And that sometimes a little higher, sometimes a little lower is that visual scatter that you see, and the way that that's quantified is with a statistic called the standard deviation, so that's 0.02. So in this case you might say, all right, whenever someone has an FFR value of, say, 0.78, what we should really write down is 0.78 plus or minus 0.02. That's the kind of imprecision. If you were to measure it again and again and again, you'd largely get values that varied from 0.78 within 2 points on either side of it. And as I mentioned, this is something that affects everything that we use in medicine, be it glucose, blood pressure, you can see cholesterol, echo, percent, right? The whole thing, everything has some variation, and that is a combination of two different factors. One part of it is how well we can measure measure whatever we're trying to measure, so that has to do with the equipment or the assay, if you will. The second part of this is that the body only regulates these things to within a certain range. For example, our blood sugars, right? The blood sugar and the blood pressure doesn't need to be kept within a millimeter of mercury, or, for glucose, it doesn't need to be kept within the same point value. And so if you make measurements over a short period of time, for example, 1 hour to the next hour, you'll notice that your blood pressure changes a little bit, or your glucose is a little bit different, because the body's homeostasis mechanisms also have a certain what we call biologic variability. So the imprecision comes from the assay coupled with the natural biologic variability. And one method that people have come up with to try to compare those in, because they all have different units, is something called the coefficient, which is a metric of the imprecision, the spread, the standard deviation, then divided by the typical average value. And you can see that something like FFR actually has a fairly good coefficient of variation when we compare it to a lot of other metrics that we use every day, day in, day out, for making clinical treatment decisions or diagnoses for patients. Let's take that same concept then and come over and apply it to FFR from angiography as well as FFR then from CT. And this is a nice paper that came out a couple of years ago where it took almost 2,000 lesions. You can see the numbers over there, quite large, from a whole different number of vendors. It turns out that the vendors largely all have the same imprecision. And what that means is that there's no bias. The two values on average are equal to FFR, but that there's this scatter, and that scatter, again, quantified by the standard deviation, in this case 0.07, so larger than what we get for invasive FFR. And it's also a little bit larger than if we go and look at FFRct. So this was data put together from over 900 vessels, and you can see again the bias is small, although not negligible. FFRct generally is a little bit more pessimistic than invasive FFR by maybe 3 points, 0.03, something like that. And the imprecision is slightly greater at 0.09. And this is something that is well appreciated on the FFRct. In fact, it's part of every single FFRct report. I think it's on the second or third page. They have this table, which comes from the FDA's de novo approval document, which you can find at the FDA website, noting that when the FFRct is within these certain ranges, this is the average difference as well as the scatter, one standard deviation. It's that scatter then that is largely 0.09 or something like that, although it does vary a little bit by the exact FFR range. So this is well appreciated and part of the reports actually that the docs get from FFRct. So to summarize all of this then, we have these various methods of measuring FFR, using an invasive pressure wire, deriving it from the invasive angiogram, or deriving it from the CT angiogram. And when we think about bias, the bias is always small. As I said, there's a little bit of bias for FFRcts, but generally for the other ones, it's negligible. The real issue then is the imprecision, right? When you start off with a pressure wire, you're able to get down to 0.02 plus or minus. For the angiogram, it goes up to 0.07. And the reason that it's greater is because of the anatomic resolution for angiograms, which is not perfect, and also for the physiologic models that drive the fluid simulations. Those are generally right on average, but each person is an average, right? Each person is his or her own unique vasodilatation and resting flow values. And so because of that, the model has imprecision to it. The CT angiogram then largely has very similar models, but because its resolution is not as good as invasive angiography, that augments the imprecision. The standard deviation gets a little bit bigger, as you can see here by the summary values. So let's think about what that means in practice. Let's say that the FFR value were 0.8, right on the upper threshold for the transition zone between what people often call positive and negative. The pressure wire then, if it were exactly 80, you would get some values that are plus or minus 0.02. So 90%, 95% of the time, you get an FFR between 7.6 and 8.4 if you just measured it again and again and again. What happens then with the invasive angiogram, and you ran one of those 6 different vendor models on it, you would say, okay, well, the true value of FFR is 80, but 95% of the time I'm going to get a value between 6.6 and 9.4 if I sat around and ran it again, took a different angio, that kind of thing. FFRct then, that 95% confidence interval goes out to 0.59 to 0.95, so wider. So what the end effect is for imprecision is that you are less and less certain about which side of that fence are you on. Are you clearly in the negative zone? Are you in this kind of gray zone where it could go either way? Or are you clearly in the positive zone? When you make an invasive pressure wire measurement, you're really tight. You know pretty much where you are. Of course, there's always some imprecision, but the minute you move away from that, it grows ever larger. The reason, as I mentioned, this happens with CT angiography is largely due to resolution. You can do a bit of back-of-the-envelope kind of calculations on theory and figure out what this should look like if you make some average assumptions about reference diameter, vessel sizes, and how well we can image things with CT angiography. And that's that theoretical expectation that I show you there in the upper left. If you take the experimental data, in this case from a study called Discover Flow, which was the initial FFRct model from about a decade ago, you can see the raw scatter. And when you bring those two together, you see that they really match quite perfectly. All of the points lie within basically that red dashed line. In other words, the scatter that we see is really dominated by imaging resolution of the CTA, which is maybe a little bit better than 0.5 millimeter. We can also see that if we look at a study that we're going to talk about here in a few slides called Reassess, where they took a look at various FFRct ranges, saw how many patients fell into each one of those categories, and then looking at how many FFRs were actually positive. So for the FFRct range of greater than 0.85, no one ends up falling in that zone. Whereas even when you go down to something like 81 to 85, well, almost 20% of those patients actually have an FFR value that's less than 80. The closer you get to kind of the cutoff, 76 to 80, there you'd expect all of them to have FFRs less than 80 if the precision were perfect, but only a third of them do, and so on and so forth, such that even when you have FFRct values less than 0.6, still there are 15% of those patients who don't have low invasive FFR values due to this scatter issue, due to this imprecision issue. The same thing happens to a little bit lesser extent with invasive angiography. I've taken the same kind of concept now and translated it down a row where we say, all right, instead of plus or minus 0.6 millimeters imaging resolution, let's assume that the invasive angiogram can get us within a third of a millimeter, and that tightens up that arc. And again, when you take data this time from a study called a FAST FFR, looking at a tool called FFR Angio, we fuse them together. Again, we see almost a perfect fit. So imaging resolution, again, continues to dominate scatter, but ultimately the physiologic model is a part of this as well. You're going to say, well, what about PET? And PET has exactly the same imprecision issue. So what we did several years ago is we brought in research subjects and we did a series of PET scans on them. 2 of them were on the same day, so that allowed us to test how much variation happened within a few hours of each other or something like that. And then we had a second group that had a PET scan one day and a PET scan a week or 2 later. And that allows us to see what happens over the intermediate term, I guess you could say. Now, largely on the day of the PET scan, if you do 2 studies, what you're really looking at is how much of that imprecision comes about from the technology, from the tool itself, that is from the PET scanner, from the flow model, from the stochastic process that is radioactive decay. All of those things mean that if you measure it even twice within just an hour or something of each other, you never get exactly the same result. The coefficient of variation, as you can see, is about 10%. Now, when you move out to a week or two later, what you see is that 10% has now grown to 20%. And the reason it's larger is you still have that same 10% imprecision from the assay, which is the PET camera in this case, but you also have another 10% that comes along because of biologic variability. The body only regulates flow to within a certain window, and when you are a week or two out, you have this extra 10% that comes along with it. So 10% from the assay, 10% from the biology, combine them together, that's the 20% that we see for test retest a couple of days apart. And so when we compare these various tools that we have, right, PET flow, as I mentioned, on the day of kind of immediate test retest is about plus or minus 10% for its coefficient of variation. If you do the same thing for FFR, just because FFR is a scale that works the opposite, right? Like 1 is the best value and 0 is the worst value. You have to turn it around. So when you have a typical imprecision of 0.02 and a typical average value of 0.8, that also works out to a 10% coefficient of variation. And for FFRct, again, there's a little bit of a bias, so I shifted the number down to 0.75, and the imprecision is now 0.09. You can see that it's about 3 or 4 fold larger than it is for PET or invasive FFR. So there's a wider range of imprecision, a wider coefficient of variation for FFRct than there is for PET flow. So what I'd like to do now is to transition to a series of comparisons, that is taking a look at the data that compares FFRct against things like SPECT and kind of routine clinical practice and ultimately PET as well, in order to understand what kind of differences exist out there and where does FFR fit in this kind of potpourri of tools that we have in order to assess patients. This was a fantastic study that came out of Denmark called Reassess, and it's fantastic because they took patients and did both tests and then went head-to-head. And I can't emphasize how important that is that by having that kind of paired comparison, you're really able to understand which test performs better against a reference standard in a far more efficient way than if you were to just do half of the patients using one test and half using the other and kind of comparing them. Because each patient then has both tests, you're really able to boost your statistical ability to see those differences. So that in Denmark, they do a lot of CTs, a lot of coronary CTs. You can see here that they started off with something like 1,500 patients, and a huge number of them, something like 1,200 had normal or non-obstructive disease. So they just pushed those off to the side, and they included then the remaining 160 or so where they thought that it was intermediate, and then they took those patients, and the ones that they could underwent SPECT, as well as sending off the CTs to a core lab for analysis for FFRct, and then all of those patients went to the cath lab and had FFR measured. So you have FFR invasively as the reference standard, and each patient has both a SPECT study and an FFRct study. When you do that kind of head-to-head comparison, what they showed, I think, was that several results that are important. The first is that this was a clinical population that did have intermediate disease. You can see the Agatston calcium scores are just under 200. There's about a third of lesions, a little over a third of lesions that are greater than 70% severity by CT angiography. And you see that the lowest FFR, less than 0.75, happens to be present in about 30% of patients. Of course, there's a relationship then between the SPECT defect and the lowest FFR value. So when patients have no reversible perfusion defect, which is the vast majority of them, only about 30% of patients had a low FFR value. And as you go down to small, moderate, and large reversible perfusion defects, by the time you get to large, every one of them had an FFR that was low. And there's kind of a continuity gradient between the two. So that shows you some of the conceptual validity behind this. So now let's go head-to-head, SPECT versus FFRct. And this is a 2x2 table where the SPECT either shows a reversible defect or not. That's what they mean by ischemia. Or the FFRct value is low or not. That was the FFR criteria. And you can see here that of the 140 or so patients, roughly half of them, the two tests agreed, right? 30 cases, the SPECT was abnormal and the FFRct was low. In 46 cases here, the SPECT was normal and the FFRct was normal. So in about half of cases, the two tests tell you exactly the same thing. In the other half, though, the SPECT was normal and the FFRct was abnormal. or vice versa. And those are the off-diagonal elements there. You can take that and reformulate a little bit by asking how often did FFRct agree with the invasive FFR value and how often did it disagree, and the same thing for the SPECT study. And here you can see that 60 and a little bit time they both agreed with FFR and agreed with each other. 11 cases they both disagreed with FFR but both disagreed, so they matched up with their assessment. And for the ones where one test got it right and the other test got it wrong, that's the 32 and 35. Those are well balanced, right? It's not like you've got 50 in one and 1 in the other or something like that. Those 60 or so scans are evenly split. So the disagreements go either way, and you can see that the ratio there between these two is essentially 1 and the p-value is not significant. In other words, using FFR as the reference standard says that FFRct performs equivalently to SPECT. They both make mistakes, but they make those mistakes with equal frequency. This is something then that is reflected in the top, which is comparing itself against invasive FFR. In the middle area, you see the 2 bars for accuracy. That accuracy, how often they got it right, is the same. There's no statistical difference there. But what happens, as you can see off to the left, is there's a trade-off in sensitivity and specificity. FFRct tends to be very sensitive, whereas SPECT tends to be very specific, and then vice versa for the other tests. So if your FFRct is negative, you can feel sensitivity rules out, right? So snout. So that means that you're not going to have a positive FFR, whereas when you had a big bad SPECT defect, you could be pretty confident spin specificity rules in that you're going to have a positive FFR invasively, and you can see how that's also reflected on the other side for the positive and negative predictive values. When you look down at the bottom, it turns out what they did in the study is that those values for SPECT and also the FFRct results were blinded from the invasive cardiologist who took these patients to the cath lab and did the FFR measurements. And ultimately in the cath lab, they made their decision based on the angiogram and the FFR values about, do we need to perform PCI or bypass surgery? So that revascularization then in the bottom table served as the reference standard. And you can see actually that we have this trade-off again, sensitivity versus specificity, but look at the accuracy, equivalent between the two, if not maybe even 10 percentage points higher for SPECT. So I think the reassess study could be summarized as saying is that using FFR as the reference standard, that FFRct performs no better or no worse than standard SPECT imaging. So let's move over to another recent study that came out. It's called FFRct. It was done in the United Kingdom, and it asked the question, does FFRct perform any differently than what is our routine daily practice here in the UK, not here in the UK, but in the UK, for how patients with chest pain, chronic chest pain, are evaluated. And so they took patients who came to their rapid access chest pain clinics across England and Scotland, and they had a fairly large number, about 1,400 of those kind of patients, who were then randomized into 2 groups. The standard group said, hey, listen, doc, you do whatever you would do in clinical practice, which is a combination, of course, of some patients got CTs, some patient got SPECT, some patient got echoes, some patients went right to the cath lab, some patients, the doc said, hey, don't do anything, you don't need any test. Or they were randomized to the experimental group, where really the option was to do CT followed by FFRct in cases. I'll give you the top-line results, and we can then dig a little bit into the details. So the primary endpoint, that's way over on the left-hand side there, was a cost issue because in the United Kingdom, it's generally a single payer for everybody. There is a private system, but generally most patients are covered through the National Health Service, the NHS, and their interest as a tax-funded organization from the population is to try to be cost-effective about what they offer for tests. And so, as you can see, there was no significant difference between the experimental arm, which again largely is an FFRct guided arm, or standard of care. In fact, if anything, it kind of said that standard of care costs were lower. What about clinical symptoms, right? So the next column over there is the Seattle Angina Questionnaire. No difference between the two. In fact, if anything, the standard group had a slightly larger improvement in their Seattle Angina Questionnaires, but wasn't statistically significant. What about quality of life scores? There's something called the EQ5D, which is the European questionnaire on 5 different domains of life, largely looking at patients' assessment of their quality of life. exactly the same in both of those groups. And then when you look at the next column over how often you have clinical events, major adverse clinical events, exactly the same in both groups. And then finally, the angiography piece was higher in the standard arm, and we'll get to that in a slide or two. So here then is what docs asked for as their initial test. As you can see in the experimental arm and highlighted there in blue, dominated by CTs and FFRCTs by design. That's how the trial was supposed to work. Only very rarely did they say no test. 96% of the time or more, they said, yep, CT, that's the way to go, get FFR needed. In the other arm, you'll see that they also were allowed to do CTs, largely not FFRCT. That happened in a few cases, but that wasn't the intention. Generally, docs could choose among stress echoes or doing specs or stress MRIs in a few tiny cases, or doing a standard treadmill testing, or sending the patient right to the cath lab. And that happened in about a third of cases. And this highlights one, I think, of the design drawbacks to forecast, and that's that only a third of the time did docs do something different than what was happening in the experimental group. In other words, 2/3 of the time they did the same thing, either no test or they sent the patient off for a CT scan. And so because it was only different in a third, that ends up making the two groups much more similar than different. What happened then over the next 9 months, which was the kind of time to figure out costing and how that had an effect? These numbers in the table then aren't percentages. They're the number of events, and in parentheses, the number of patients, because sometimes you might order, say, 2 CTs on a patient or something. And this does include the baseline tests as well. What we see then is there's a real difference in non-invasive testing by design. That's the way that they wanted to do it, not only at baseline, but then through follow-up as well, because patients in the experimental group might need another study. They might need a stress echo or a treadmill test or whatever down the road. So you can see they kept track of that. Invasive coronary angiograms happen more often in the standard group, but you can see that the absolute difference there is maybe about 40 caths. And those 40 caths are largely all the ones that were ordered in the standard group at baseline anyway. So it's interesting that that's something that's influenced by people's initial decision about what this patient needs. Myocardial infarctions, intriguingly, although it didn't reach statistical significance, were higher in the experimental group. And if you look then down at visits to the emergency department or the outpatient clinic or total hospitalizations, no significant difference between the group for those kind of healthcare utilization pieces. What about adverse events? You can see that the total number was extremely similar between the two groups. The only column, the only row that's a little bit different there is at least one non-fatal MI, not statistically significant, but again, 3-fold higher in the experimental group than the standard group. Intriguing, more hypothesis generating though, because the top line result's negative. And when we delve down a little bit into the exact Seattle Angina Questionnaire scores at baseline, no difference between the two groups as expected by randomization. But then 9-month follow-up, you can see that both groups improved their quality of life. Their Seattle Angina scores went up, meaning less angina burden, but it went up equally in both groups. So they ended up at the same place 9 months later. So I would say that the takeaway result from forecast is that FFRCT is not cost-saving to the system. It doesn't somehow lead to better patient outcomes or less or fewer symptoms. There is this issue of it reducing the number of invasive angiograms, but it makes up for it in cost anyway by ordering all these other tests. And I think was largely interpreted by people as a neutral result. It's not that FFRCT added any advantages there. Finally, most relevant maybe to the topic that we've been talking about here, let's take a look at FFRCT and compare it to PET flow imaging. And the study here that was just fantastic was done by Paul Knappen's group out of Amsterdam called Pacific. And this was where he did it right. He did a group of patients and did every single test on them at the same time in order to understand in an individual patient which one got it right. Did CTs on them. Those CTs, in cases where image quality was good enough, were allowed to be post-processed for FFRCT. Did specs, did PETs, did fused imaging, so SPECT CT or PET CT, and then took patients to the cath lab and made invasive measurements of FFR. And that FFR then was what was used as the diagnostic reference standard. So when you have all these head-to-head matchups, who comes out ahead? Well, you kind of know the answer already. It's PET, of course. So when you look at the per-patient sensitivity and specificity, you look across that row, of course, there's always a trade-off. That's what receiver operating characteristic curves are down in the lower left. So, how to look at it? Well, the best way to look at it then maybe is a little bit of the area under the curve, or in some cases, if you want a more simple summary metric, you can add the two ones together. And it turns out that PET scans had the highest accuracy for the diagnosis of ischemia as defined by a reduced FFR value invasively. And it's interesting that some of these notions we have of multimodality or fused imaging, where you take CT and you add on SPECT, or you do CT and you add on PET, that those combined anatomical and functional assessments didn't add incremental diagnostic value. So it really seemed as if the money was on PET flow imaging, and that performed best among all these tests. So it puts PET then ahead of SPECT, it puts PET above CTA. What about FFRct, you ask? Well, there was a separate paper that then came out in JACC about 2.5 years ago asking that question. And part of the challenge in Pacific is while they got CTAs in everybody, not all of those CTAs then could be post-processed for FFRct. And of course, some patients, for whatever technical reason or claustrophobia or what have you, were unable to go PET imaging. So PET imaging failed in about 2% of subjects, whereas FFRct assessment failed in 13% of subjects. And so this comes down to this diagnosis of intention to diagnose. That is, when a patient comes to clinic and says, hey, doc, I've got some chest pain, whatever, you say, okay, we need to figure this out. Let me order a test. Well, if the test fails for whatever reason, like the CT was non-diagnostic or the PET scanner failed or whatever it is, they still need the diagnosis, right? And so you have to ultimately say, well, okay, we're going to have to send you to the cath lab to get this answered, since we weren't able to do the test we wanted to do. And that's this notion of not just counting the cases where you were able to perform the test, but looking at everybody who came in the clinic door and asking, in how many of them were you able to reach a diagnosis successfully? That's this intention to diagnose. And when you do that, the diagnostic accuracy for SPECT, as you can see, is significantly higher than the rate for FFRct. And that's a combination of things, not only a combination of how many patients are able to get these studies, but also then I think the value of measuring absolute flow as opposed to simulating it using FFRct. So coming back down to this, I would take all that data that we've been thinking about and summarize it as follows. And this brings together the reassess study, it brings together Pacific and also forecast. When we look at imaging failure, it's clear, not just from these studies, but from a lot of other studies, that the contraindications to FFRct or just CT angiography in general are greater than they are for PET or SPECT imaging. When you think about renal function and contrast and just the ability to reduce the heart rate and get really good diagnostic CT images, those ones are something that just don't affect nuclear perfusion studies of either kind, both PET or SPECT. And so most patients, far more patients, are able to then get a diagnosis through perfusion imaging. What about when we compare that accuracy then against FFR? In Pacific, remember, it was attention to diagnose, and in reassess, they only looked at successful scans. No matter how you cut it, PET comes out as having the highest accuracy. And actually, when you look at it, SPECT and FFRct look much more similar than they do different, if not a slight edge to SPECT, which is interesting to me. If you look then at accuracy comparing to what the interventional cardiologist did in the lab, taking the patient anatomy and the invasive FFR values and putting it all together in order to make a decision about revascularization, again, statistically, those two values, 73 and 63, don't differ from each other. But again, if anything, a slight edge to SPECT at the end of the day. I really think that this is moving forward, and I'm excited to see more randomized trials looking at what kind of gatekeepers should we have to the cath lab. And a very important one that I wanted to talk about here at the end is the MR-informed, Mr. Informed trial that came out of UK and Germany about 2 years ago or something like that, where patients who had, again, kind of chest pain syndromes and chronically trying to be worked up for it were randomized to MRI-informed strategy, where they did a cardiac MRI study, again, looking at perfusion only when it was positive going to the cath lab, and only treating the areas where there were perfusion defects on the MRI scan, and if it was negative going to medical therapy, versus taking everyone to the cath lab for an FFR-informed strategy and using FFR then to make decisions. And what was seen in this study, as you can see from the outcomes curves on the right-hand side, is that MRI was non-inferior in terms of major adverse clinical events. Of course, if you ask patients, would you rather have an invasive angiogram or first an upfront MRI scan, they would all vote with their feet probably and do the MRI. And if you also look at it from a healthcare systems perspective, it's probably cheaper to pay for MRIs, and then only those who need to go to the cath lab go to the cath lab for a vascularization. So I really think that the future of non-invasive gatekeepers, and I was delighted to see a couple years ago in the European Heart Journal this, if you will, kind of global analysis of many of these tools that we have out there, from invasive angiography to stress echo, EKG, CTA, SPECT, PET, MRI, the whole gambit, using FFR as a reference and looking at how these perform in a large number of studies. And when you look at sensitivity and specificity, I think we can really say that flow-based advanced imaging technologies like cardiac PET, but probably also cardiac MRI, are ones that provide the greatest ability for us to understand exactly who needs to be going to the cath lab. And I really think that's the future and where this is going. So I thank you so much for your attention. It's been a pleasure talking about this, and look forward to having some discussions about questions here. Thank you so much.
All right, well, thank you so much, everybody. Now we go to the live part of this, which is a bit of a Q&A session. I've got Derek here from Breako who's helping curate some of the questions as they come in, and he's passed me a few already, so I'll just pick from the top of the pile. Some are simple and short, so I'll begin with this one. It's asking about the reference for the imprecision on FFR derived from CT. And there are really two places you can find that information. The first was if you look actually at the at any of the FFRct reports, it happens to be a part of every single one on the second page. And the reason for that is that it's actually was part of the de novo application that's sent to the FDA. So if you look back on my slide deck, you can find that one, or if you go to FDA and search for the approval for FFRct. The academic place you can find it as well was back in 2017. In JAMA Cardiology, Christopher Cook and some of his colleagues pooled the data from I think it's about 900 or so vessels and took a look at it. So if you're looking for where to find some reference for that, it's actually, again, I think the most important part is it's on the FFRct report as well. So when colleagues come to you and they say, oh, listen, the FFRct is, whatever it is, 0.82, you can just flip over the page and remind them that something like 0.82 actually means, 0.82 plus or minus 0.08 or 0.09, something like that. So it can vary quite a bit due to that imprecision. The second question I'm taking here off the pile is looking at ways to distinguish among a couple of kinds of disease patterns. One is large vessel disease, real epicardial stenosis, diffuse disease that's not just focal, microvascular disease. They ask without FFR invasively. And the answer is absolutely. And the pattern, this is something actually I'll be talking about a little bit during my ASNC session tomorrow with some specific examples. But, conceptually, when you have a focal lesion in a epicardial vessel, what happens is you immediately will invasively notice a large focal pressure gradient. But on perfusion imaging, you'll see a very abrupt transition as the perfusion defect begins. What happens with pure diffuse disease invasively is you have a diffuse pressure gradient if you move the pressure wire up and down. And what you see on perfusion imaging then is a gradual tapering and flow from the base of the heart down to the apex, since almost all of our blood vessels naturally run base to apex. So you'll start off with, say, warm colors at the base, whatever your color scheme is. I like rainbow schemes, red or white. Kind of in the mid part, it will transition to green and yellow, and then maybe even a touch of blue by the time you get to the apex. Microvascular disease is something that is uncommon in isolation. Many patients have both epicardial and microvascular disease at the same time, but for patients who have pure microvascular dysfunction, that is, there's no way for them to augment flow up to normal levels in response to vasodilator or other types of stress. Really, the only way for doing that is to understand flow measurements, and so that's something obviously we can do quite routinely with absolute flow quantification. Invasively, what you'll see on those vessels is that there won't be much atherosclerosis in the epicardial vessel. You put down the pressure wire, and the gradient that you have at rest versus the gradient that you have in response to a vasodilator drug is about the same, and that's because the vessel doesn't have a lot more flow going through it because the microvasculature hasn't vasodilated and the flow reserve is quite low. So those are the kind of broad strokes in how to distinguish those three groupings, either invasively with a pressure wire or non-invasively with myocardial perfusion imaging. Another question that's come up here asks, should we be performing blood flow measurements, FFR or FFRct on the same patients? Is that something that's helpful, and when might that be useful? And I'll tell you that my approach is largely a two-step one. When a patient comes for evaluation, I think the first question that I like to answer is the physiologic necessity of revascularization, or at least the physiologic explanation for whatever symptoms the patient's having. And so that's really something that I think is best answered with perfusion imaging with flow measurements. Largely it's going to give one of three answers, although the first two really dominate. Some patients are going to have epicardial reasons for their symptoms. That's that focal lesion or severe diffuse disease, and that's something that's going to be apparent from the flow images. The second category is that some patients are going to have subendocardial hypoperfusion. That's something that you can see on the cross-sectional images. The kind of simplistic notion of that from SPECT is TID, but there are other ways of quantifying that as well. But the fact that a lot of patients who have risk factors and mild atherosclerosis have symptoms because they have a subendocardial hypoperfusion, because that's the layer of the myocardium that's most susceptible because it's exposed to high LV filling pressures. Of course, it has only perfusion during diastole because of the way the coronary circulation works. And then also it's kind of at the end of this supply chain, as it were, and so it's most sensitive to that area. The third group, which was brought up in the previous question, is that some patients will have a microvascular disease, and as I mentioned, that the flow measurements are the way to go for those ones. So the first question then, is there physiologic necessity of doing revascularization? It's really only the big bad focal epicardial vessels that need that, and those are the ones then that I often turn over and as a second stage do some kind of evaluation. Now, depending on your style or your tools that are available locally, sometimes a CT angio can be useful to try to do procedural planning, or sometimes go right to the cath lab and kind of figure it out. For example, there was just a patient that I was been dealing with over the past week, had a very large, severe stress-induced defect at PET, but had prior bypass surgery, and we're trying to understand procedural planning. How are we going to accomplish revascularization? Is it the grafts that have failed? Is it the native circulation, and so on? And so that's kind of a combination where you can start off with perfusion imaging for the physiologic necessity, and then use anatomic imaging to help plan the procedure itself, just like you do with TAVI, right? We do an echo or something, the patient has severe aortic stenosis, great, then we get the TAVI CT in order to plan the procedure and get the job done. Question for Dr. White up in San Antonio. Why did NICE in England land on CT as the test of choice? And it's a great question, and I think speaks to this notion of system infrastructure. And when you've got a lot of a tool that's widespread and you have people trained to do it and to use it, then that's something that can be rolled out in a way that is fairly cost effective and doesn't require a lot of new investment in technology. And if you think about it, CT meets a lot of those requirements. There are a lot of CT scanners, even in countries like England, that have decided to consolidate medical imaging into kind of centers of excellence. It's something that there are a lot of techs that can go out there and run the scanners. It's kind of one size fits all, get them on the table, give the contrast, push the button, and for that reason, they didn't, I think, need a lot of extra infrastructure in order to carry that out, compared to, say, investing in retooling the whole country to do something like cardiac PET or cardiac MRI. There's certainly centers of excellence for that within the national health system in England. But to roll that out across the whole country at the kind of scale that they would have needed to, I could see how that would have been challenging for them. So I'm not trying to say that it's right that we should do CT imaging first, but I'm just trying to explain why I think they lit on CTs as their initial test of choice. And what I think is a little humbling in a way is that those recommendations were largely based on the NICE methodology then of looking at availability, looking at cost effectiveness, looking how they're going to actually be able to logistically roll this out. And it was only after that that they went and did a trial like Forecast. And guess what Forecast showed? Forecast showed that it's not cost savings, and it doesn't have any advantages for other clinical endpoints versus other tests that were part of Forecast in the kind of non-FFRct arm. So actually, while the idea then made its way into national recommendations for chest pain evaluation, it's humbling that only afterwards did the randomized trial get done and actually not focus on that. Related questions come up then. The NICE guidelines advocate for CT over PET. Are they wrong? Well, again, are they wrong? It depends what you mean by wrong. I guess if you're wanting to provide a test that allows rapid dissemination throughout the country that picks off the patients who don't have any atherosclerosis, CT is certainly a very reasonable choice, although you could make the argument that perhaps we shouldn't be doing any testing in those kind of groups. If you look back at trials like PROMISE and look at the very low event rates that happen in patients who are classically referred for a CT angiography, or SPECT for that matter, in a large part of the country, what you see is that there are enormously high rates of completely negative tests. And that's great. I suppose they don't need to go on to invasive angiography, but you might realistically ask the question, could we be doing even less imaging in that group, or in somehow enriching that so that we don't have such high rates of negative testing? That'd be another way of being, I think, judicious about using medical imaging. Another question come up here. Do you think the imprecision with FFRct will decrease with better equipment, or is it stuck because of limitations that can't improve? And that question, it's almost like it got planted in the audience. I'll tell you, we wrote, and when I say we, my colleague Lance Gould and Rick Kirkady and I wrote an editorial. It's probably now about a decade ago, and it said, simulating physiology from anatomy, are there fundamental limits? And in that editorial, we really looked at that question from a lot of different vantage points. As I mentioned, history is now replete with 4 decades of people doing this kind of imaging simulation work. And the basic message is that you are stuck because at some point, the heterogeneity of the physiologic response as well as the fundamental imaging resolution in the system can only reduce your imprecision so far. And I think that's why it makes sense when you look at the imprecision for FFR versus angio FFR versus CT FFR. You see that growing imprecision, and that's a reflection of those two components. One is the imaging resolution, but the second one, that even imaging resolution, I could go even further, like, well, why don't we do OCT imaging and use that to reconstruct the core and everything? What you bump up into once you get to even intracoronary imaging methods are the fundamental assumptions behind the physiologic models, and they work reasonably well on average. That's why on average the two values end up being the same. But you can imagine that just like people come in all different heights, and you say, well, what's the average height? Okay, it's 5'10", but you're going to find people who are 6'1" and people who are 4'8" and everything else in between, and that's the same kind of stuckness that limits the imprecision for simulations fundamentally. Next question then is, what is my opinion on CFC as measured by our group here, Lance Gould and myself? Is it superior to PET-derived CFR for detection of FFR positive lesions? And again, this is a fantastic question, and it's almost like it was planted. It's like it's a free advertisement for my talk that I'm doing tomorrow during my ASNC session. So if I could ask that whoever asked that question tune in. We're doing a combined session tomorrow with SCMR. I think there are 4 of us giving talks on various things, and mine is on addressing this very issue. That is, taking a look at several cases of mine over the last couple of years and looking at these, if you will, discordances that can happen between FFR measurements and then PET-derived measurements of flow, be it coronary flow reserve or a coronary flow capacity. And I'll just give you maybe kind of a quick teaser for that one. And that's that I'm going to show you some examples tomorrow of FFR positive lesions that have fantastic flows or fantastic flow reserves. And I'll just say that as a teaser, not to give away why that happens, but to say that those are lesions that I think there's strong evidence that we can treat those conservatively. And indeed, you need to be a little bit careful when you're making FFR measurements, because unless you understand the absolute flow levels as well as the CFR, you can end up seeing that they're FFRs that are positive that we should stay away from completely. And I'm so intrigued by this, I'll give you one last little brief teaser. There's a beautiful slide I have in there where they took marathon runners in Germany. So they got about 100 marathon runners, asymptomatic, had to be at least age 45, and they did CT angiograms in all of them. And they found a subset, fairly large, I think it was about 50 or 60, who had no coronary atherosclerosis whatsoever, right? So no coronary calcium, no plaque on the CTA, looked great, right? They took all of those CTAs and they ran them through one of the FFRct simulation programs. And guess what? 30 or 40% of them had FFRCTs that were low, mainly in the distal apical LAD. The reason for that is these are people who have great flows, they have high stress flows, and what drives pressure loss in the vessel is the absolute level of flow. And so the LAD supplies more mass, and so these people are really able to crank stress flow up fantastically. They're obviously asymptomatic, they're running marathons, right? So this disconnect, if you will, between pressure measurements and flow measurements is something that is so fundamental, and that's something that I hope you'll join us for the session tomorrow at ASNC, where I'll show you some of those specific cases and delve into more detail.